Just to encourage the speakers, we have almost 400 attendees today. Thank you. So we'll just go to our next speaker, Dr. Ahmed Mustafa. Dr. Ahmed Mustafa, he's going to talk today about a day in the life on call for deceased donor in Canada. How do we manage it and the role of the lab in the decision making? It sounds very interesting title, Dr. Ahmed, and I hope the attendee will enjoy your talk. Welcome, Dr. Ahmed.
Oh, thank you so much, Dr. Amna, for this nice introduction, and thanks for this invitation. This is not my first time to attend this conference. Actually, it's my second time, and it was very nice to see you in person. And thanks, Dr. Fakhri, as well for this invitation. So I'm just sharing my screen now, and I'm going to put it into. Okay. So I think everyone is seeing my screen. So let's start now. So yeah, the objective of my talk today is I'm going to convince you, or at least at the end of the talk, you will be convinced that the lab do an important decision making for organ transplant. And during my talk, since I'm going to give you like a virtual tour or a virtual reality on how we manage this into the lab. So I will take you from the morning till the end, till we get a transplant happening in Canada. And during this presentation, I will do one case study so that you can be familiar on how we manage these cases in Canada. So since it's a virtual reality, so I would like to start my day usually by hiking, relaxation, or fishing. However, most of other parts of the country see this as we start our day by skiing, but in real life, this is how we start our day. So I usually have to shovel my driveway just to get my car out, and sometimes it takes 2 hours in the morning just for shoveling. And apart from the harsh weather in Canada, Canada is actually the largest country or second largest country in the world, and it has only a 38 million population. So if we actually measure the distance from the East Coast to the West Coast, it's around 5,514 kilometers, and it takes around 10 hours flight to fly from this area to this area. And this is a challenge because, for example, when these individual living in the East Coast finish their shift, people in the West Coast start their shift because there are 6 time zones and there are a difference of 4.5 hours from the East to the West. But the nice thing about that we have 21 transplant centers in Canada, and we only have 15 HLA labs. And I'm going to focus into one lab, which is definitely going to be my lab. And my lab is actually situated in Saskatchewan, and the city is called Saskatoon. I know that the name is a little bit difficult, but this is our hospital here. This is St. Paul Hospital, and it has a very major history in transplantation in Canada because the second deceased donor happened in Canada happened in this hospital. So because of the large area, and as Dr. Noura mentioned, there must be a regulatory affairs that control all these kidney around the country, because we share organs, like every province share organs with the other province. So this is actually guided by the Canadian Blood Services. And from its name, actually, again, the Canadian Blood Service has 2 main functions. The first one is transfusion. So it provides blood transfusion to all Canadians, including platelets, plasma, and everything. And also the other function is organ and tissue donation, which I'm going to focus today. And it's only focused on the national level. So for example, it controls the national organ waitlist. And I'm going to speak about it today, about what is the national organ waitlist. It also controlled the kidney pair donation, and it controlled the highly sensitized patient program and the Canadian Transplant Registry, which is equivalent to the UNOS, if you are familiar with the United States organization. And also, it is important for the interprovincial organ sharing, especially for the heart, highly sensitized heart cases. And this is actually controlled by two committees. The first committee is the Kidney Transplant Advisory Committee. And this committee is formed of all the medical nephrologists, medical director nephrologists across the country. So I mentioned there are 21 transplant centers. So each center has only one medical director of this program. And the other committee is the National HLA Advisory Committee. And I'm one of them because it is only the director of the HLA labs, and we are only 15 labs in Canada. So I'm one of the 15 people in this committee. And then each committee has its own chair, which recycle every 3 years. And also the Canadian Blood Service has actually played a major role in one of the first trial in the world, which is transferring a lung transplant from one place to the other using a drone. So we have seen drone transferring like goods like Amazon and things, but this is the first time in the history that we can see a drone transferring a lung transplant. And you can see it very simple, but actually it took 2 years of different organizations involved, ethics, and a lot of people involved. Even there was someone from the patient advisory committee that was involved to see that how this can happen. And actually, it happened 2 years ago, and the lung transplant was transferred from Toronto Western Hospital into Toronto General Hospital, which is around 1.5 kilometer, but it took around 5 minutes. And in order to proceed, they also have to take the consent from the patient. And imagine this is a patient who is in a life support and who is actually need this lung. And this patient actually agreed to transfer the only lung that can keep him alive. So actually, we all appreciate and acknowledge the brave of this patient who has agreed to transfer his own lung using the drone. So this is the National HLA Advisory Committee, and it actually formed in 2006, and it include and the aim of it is also like important for regulation and making sure that all the labs speak the same language. So it's important for standardization. As I mentioned, the members include all the medical lab directors, and also we include the chair of the key tech so that we can speak to the nephrologists through this committee. We meet once every month virtually, and then once in every year face-to-face in Toronto. So let's now switch gear, and I don't mind if you can put your answer into the chat box. So for example here, who is accountable for patient transplant rejection? I'm going to give you multiple answer, and I would like to see how you would respond into the chat box. I will give you only 10 seconds to respond. So who is responsible? Is it the lab or HLA lab? Is it the patient? Is it the nurses? The physicians, pharmaceutical company, maybe the immunosuppressive is not sufficient, or all of the above? I'd like to see your answer in the chat box. Give you 10 seconds. Actually, none of the above are responsible for that, and I will let you know why this is why none of the above are responsible for transplant rejection. So the idea or the idea of transplantation is not just like a one-man show. It is a committee. So in our center, we have what we call transplant round committee, and we meet twice every month. And this committee is formed of a transplant nephrologist, transplant surgeon, transplant nurse coordinator and donor nurse coordinator, and also it includes myself, which is the medical director of the lab. We meet twice every month, and then we agree, all of us agree on which patient is going to be listed for transplant. So as soon as we receive the waitlist patient from this committee, then we group this waitlist patient into 4 different groups based on their blood. And we add all these patients into our database. Later on, we collect blood samples, and then we do the HLA typing for them. And then we also do HLA antibodies. And then we collect all this information again, and then we put it into the computer system. Every 3 months, in order for this patient to be eligible for transplant, this patient has to give us a serum sample to test for the antibodies. And then we put these antibodies into the computer system. And also, if this patient, you know that these are chronic patients, so sometimes some of them will receive multiple blood transfusion. So we consider this as a sensitizing event. And then 3 weeks after any sensitizing event, they have to give us another blood sample to test for the antibodies, same as vaccination. And I have published a very nice article to show how does the effect of vaccination on the HLA antibodies. And now, after we test this patient with the HLA antibodies, now we can group these patients into 2 groups. The first group, and this is actually the province where is my transplant center. So the first group is the patient that has a CPRA below 95%. These patients are actually listed locally into the province. And the other group is the patient that have more than 95%, or patients who are very difficult to transplant. Now these patients are listed nationally, so they can get donor from every place in the country. And this is why the Canadian Blood Service play a major role in this organization to organize this national wait list. So how this organization works? This works through what we call the Canadian Transplant Registry. And this Canadian Transplant Registry is equivalent to the UNOS, or the United Network of Organ Sharing in the United States. So for example, here we have in Saskatchewan, we have a patient. This patient have a PRA of 95%. So we will add this patient to as a lab, we will put this patient into the CTR, or the Canadian Transplant Registry database. Now, let's say, for example, after 4 months or 1 year, Edmonton, which is a different city, they have a deceased donor. And the family decided that they want to donate their organs. So the HLA lab in Edmonton will put the typing into the same Canadian Transplant Registry database. The next step is the donor coordinator in Edmonton will run a virtual cross-match across the country until this donor will hit one of the highly sensitized patients. So for example, if this donor hit a match into Saskatoon, then the donor coordinator in Edmonton will contact the transplant coordinator in Saskatoon and will let them know that there are a potential donor in Edmonton that is matching our recipient in Saskatoon. The transplant coordinator in our place will contact myself and will contact the lab and will contact the nephrologist to have a look at this donor. So in the lab, we evaluate the immunological risk of this patient, and the nephrologist evaluate the medical condition of this patient. So now let's move on into a case study, and which was a result of this organ sharing that I'm going to present shortly. So this case study, actually, a baby was born in 2001, and this baby was diagnosed with end-stage kidney disease in 2003 due to the prune belly syndrome. And if you are not familiar with prune belly syndrome, they have lost their abdominal muscle. They don't have abdominal muscle. And that's why you can see the abdominal muscle is shrinking, which looks like the prune, which we are going to see it very soon in Ramadan. It's a fruit, but when it becomes dry, it looks wrinkled. And also, these patients have dilated non-obstructive uropathy, and usually they end by renal failure. The patient went into the peritoneal dialysis in 2004, and in 2004, he received a living donor kidney transplant from his mother. And here in the top, you can see the HLA typing of the patient, and on the bottom, you can see the HLA typing of the mother. And you can see that the patient is matching or haplomatched to the mother, obviously. So here is the number of mismatches between the patient and his mother. And you can see that there are some mismatches in the B, the C, DR, and DR3, and DQ alpha, and also the DP beta. Unfortunately, the patient lost the kidney in 2021 as a result of antibody-mediated rejection, and the patient went into dialysis. So after 17 years, the patient lost the dialysis. And here, the patient actually developed antibodies against the DR17 for his mother with an MFI of 2,229, and also DR beta 3 with a lower MFIs of 822, and also developed DQ alpha. And this is important here because I know some labs ignore typing of the DQ alpha. So if you ignore typing of the DQ alpha, you will ignore a major event of rejection, because I believe this is the major event of rejection with this high MFI. And with the pathology, this patient has C4D was diffusely positive, PTC capillaritis, interstitial inflammation was present. But here I'm actually putting to you because I want you to learn more about histocompatibility. And this figure here is actually a histogram that comes out of the Luminix assay, which we do the single antigen assay. So if you're not familiar with this histogram, on the y-axis, this is the mean fluorescence intensity, or the MFI. On the x-axis is the beads, and this is why it's called single antigen bead. And every bead is corresponding to an antigen. So for example, bead number 44 correspond to antigen DQ2 or DQ alpha 05. So you can see here that the patient developed DR17 with an MFI of 2,229, and also DR52 with a lower MFI. The other thing also, the patient developed DQ alpha with very high MFI, as you can see. But the reason I put this figure is to show you something very important here, which we also use in our lab, is the patient developed antibody, because you know now antibody does not bind to antigen. Antibodies bind to epitopes present in the antigen. So here the patient developed antibody against the 74R epitope, and this 74R epitope is present in the DR17 and the DR52. So they are cross-reacting together. And also the patient developed antibody against the 40GR, which is the different epitopes. And you can see that this 40GR is present in DQ alpha and also present in DQ alpha 5 and DQ alpha 4. Although the patient was not sensitized against the DQ alpha 4, but he developed antibodies against the DQ alpha 4 because of the shared epitope here. So in 2021, this patient was weaned from all immunosuppressant, and we only kept him at a low dose of prednisone 5 milligrams. And after we removed all this immunosuppression, his CPRA went up from 71% to 95%. Remember this number, because now the patient is eligible to be added to the wait list nationally. And the interesting here, because I'm more biased to histocompatibility, I looked at this patient developed the entire DR antibodies. And if you look here, he developed 25 different DR antigen. and all of them express one epitope. So basically, this patient developed one antibody against the 98K, and this 98K is present in all these antibodies. That's why they cross-react. And also the same here for the DQ alpha, which I mentioned before. And here also for the DP beta, he developed one antibody against 9 DP antigens. So only 3 antibodies this patient developed, and it was able to cross with every most of his antigen in the single antigen bead assays. So let's get in deep here and give you a little bit background on what I'm saying here. So I know all of you are familiar with HLA class 2, and I'm not going to explain it, but this is the alpha chain and this is the beta chain. But in real life, this is not how the class 2 looks like. In real life, this is how actually the class 2 looks like. For example, this is the HLA-DR crystal structure, and what you see here is the alpha chain. What you see in blue is the beta chain. And what you see in brown here is the peptide binding groove. And if you look here on this yellow spot here, this is where the 98K epitopes are present. So it's a surface epitope. That's why it's very immunogenic. And if you look here on the other side on the HLA-DQ crystal structure, you can see where is the 40GR epitopes are present. And this is also a surface epitope. And this is where the antibody binds. And again, this is the epitopes that are shared with all the entire reactivity in this patient. So now in 2022, the patient was listed into the Canadian Transplant Registry or the national wait list. But we updated the typing using higher resolution typing. And I will show you why. What is the significance of high resolution than low resolution typing here? Because here you can see the patient has the B, HLA-AB, and it was 4403. So please remember this number because I will come back to this number again. This is the HLA typing of the B antigen of this patient. And here also we put the cumulative versus the current CPRA. So here you can see that in 2023, when we listed the patient, he was 95 PRA, and this was about 32% class 1, 94% class 2. But now, later on, he developed more antibodies, and it became 97 CPRA with 80% class 1, 94 class 2. So when we tested the single antigen for the class 1, so here now is A and B antigen, we found something really interesting here. And I added a question. I would appreciate your answer in the chat box. So for example, here, I don't know if you can see my screen very well, but the patient developed B44 antibody, and you can see that the MFI is very high. It's almost 11,000 here. But what interesting I have seen in the same one here, that one of the beads of the B44 is actually complete negative, and one of the bead is complete positive. So if you put yourself into mind, like if you are a medical director of a lab, what would you call this HLA-B44 antibody? Would you call it true positive, or it's actually a false positive, or it's true negative, or it's a false negative? So any clue what would you do if you are in my situation? Yeah, I need one answer only. Okay, so if no answer, I will tell you what we have done here. So you can see here that these MFIs are above 1,000, so it is above our cutoff, and this is below 400, so it is below our cutoff. So it's clearly that the B44 on the right side is negative, but the B44 on the left side is positive. But when we clicked a button to see the beads itself, high resolution typing, we found that the bead on the left is actually B4402, and the bead on the left is 4403. And if you remember the typing of the patient was typed as B4403. So that's why he did not develop antibodies against his own antigen, but he developed what we call allele-specific B44 antibodies. And this is possible that the patient can develop allele-specific, not antigen-specific. And that's why I'm stressing the importance of high-resolution typing here, even in solid organ transplantation. And here I'm just showing you the difference between the B4402 and the B4403. So what you see here is the complete protein sequence. And what you see on the top here, these numbers are the location of this protein sequence. And the dashes means that the 4403 is very similar to the 4402. But on here, in this point, you can see the differences between the 4402 and the 4403, which lies in the lysine present in position 156, because this is 160. So if you go for amino acid before, it's going to be 156. And here is the location of this epitope. So the patient developed antibody against the specific epitope, which is 156D, because 156D is in the 4402, but 4403 has lysine and 4402 has aspartic acid. And this is why the patient did not develop antibodies against their own, but develop against the other antibody. So in December 2023, the patient received a national offer. So we received an offer from Edmonton. And when they called me in the middle of the night, they asked me, would you accept this offer? So I looked to do virtual cross-match. And here is the patient typing. And you can see that the donor, the deceased donor, has B44. So I am, as a lab director, the first thing I would say, oh no, I'm not going to accept. There is a chance that this patient will reject because the virtual cross-match is actually positive. So it is not a case that we will proceed. But in my case, I asked the lab to give me, because the lab has done the typing by low resolution. So I don't know if this is 4402 or 4403. You can see here the patient is 4403. So what I did is I asked the lab in the middle of the other lab in the other city to give me their typing, the raw material of the typing. And you can see here that the lab proceeded and gave me the typing of the patient of their donor, and it was 4403. So I accepted the organ, and I called the nephrologist, and I said it is a good go to go and transplant this patient safely. But the nephrologist was a little bit worried because of the 44 and the allele specific. So he said to me, what if we actually bring some blood from Edmonton to Saskatoon, and then we can do the cross-match before accepting the organs, because it's still that the patient is on life support. And here is our province here, Saskatoon, and the blue is Edmonton. And this is around 6 hours by car drive. So if we try to get blood from Edmonton, it will take us 6 hours drive to reach Saskatoon. But we were able to use the helicopter or the STARS ambulance, and we received the blood in 30 minutes. And this was the most expensive blood transport. It cost us $10,000 for transportation of this blood sample. And unfortunately, after we received the blood sample and we did the cross-match, it was cross-match T and B positive. And we tested, as you can see, 3 different serum. So this was actually a shocking to me, because I was telling the nephrologist it is a good to go, and actually the cross-match came as positive. So I said to the nephrologist, wait, it might be the patient has some autoantibodies. So let me do an auto cross-match first to confirm that this is not the case here. And when I did an auto cross-match, the auto cross-match came negative. So we were all puzzled. So what is the cause of this positive cross-match? So as you can see here, the nephrologist was puzzled. And then I said, wait, it might be that Edmonton had an issue in their typing. Maybe they did the wrong typing. So let me repeat the typing in our lab again, and to confirm that it matched the typing in Edmonton. So I took the blood sample and we ran it on real-time PCR, and in under 90 minutes, we were able to proceed with the typing, but unfortunately, there was no discrepancy between our typing and Edmonton typing. So again, the nephrologist was puzzled, and I was actually pulling my hair and thinking what's going to happen. And the surgeon was saying, oh my God, what's going to happen? I'm not going to proceed with the transplant. So to cut the story short, we went into a Zoom meeting at 3 o'clock in the morning. So in 3 o'clock in the morning, we all went into Zoom meeting. And then we talked to the nephrologist, and we decided to do a session of plasmapheresis and give them some induction, because on my case, I said there is definitely no antibodies and it is good to proceed. But as you can see, the nephrologist was convinced and I was okay. But again, the surgeon was not happy, and you will see why he was not happy. So they give this patient induction therapy, ATG, and 4 plasma exchange or plasmapheresis. And I don't know if this was a wise decision from the nephrologist or not, but this is what we did. And then what we did is we repeated the cross match. So as you can see here, before the plasmapheresis, it was positive, and even after the plasmapheresis, it was positive. So plasmapheresis did not do anything in this case. So the final decision is we all agreed to transplant this patient because we don't see any reason for this positive cross match. So I went to bed, and this was actually my dream. As soon as I went to bed, this was around like 5 o'clock in the morning. So we went to bed, and I dreamed that the kidney is rejected. And in the first time of my life, actually my dream came true. And 5 minutes when they transplanted the kidney, it turns to purple blue. And the surgeon called the nephrologist to show them how does the kidney looks in the operation theater, and he advised him to go to talk to the parents to remove the kidney from the organ. And the nephrologist actually went to the patient family and he talked to them, and they agreed to remove the organ from the patient. But as soon as the nephrologist came back, the organ started to turn reddish. It was not the best, but it was sufficient for the surgeon to close the suture and give it a try. And then they called me back in like half an hour, asked me for an urgent donor-specific antibody. And I actually did another donor-specific antibody, and there was no any donor-specific antibody. And here is actually a screenshot of the creatinine of this patient. And you can see that the creatinine was 717 before surgery, and it went to 803 and then 838. And this is why they were concerned that there is a case of rejection. But when the biopsy came back, the case came as acute tubular necrosis. So now I was relieved that it's not a case of AMR, and I was able to sleep again. And here you can see that this is the creatinine, the graphs of the creatinine. So here, the day of the surgery, and it went up, and then they give them a hemodialysis, and then it went up again, and then it slowly came down, and the kidney started to work, and the patient stayed in the hospital for almost a month, and now the patient is doing really well, and the patient survived. So the take-home message of this case is we have to do our best to save someone's life. Don't ignore DQ alpha antibody as they could be deleterious. The importance of accurate molecular typing. The importance of high-resolution HLA typing in some cases. Teamwork is the reason of success. And in the end, our message is the same, which is patient health and safety. At the end, I would like to thank my team who did an awesome job, who did not sleep for 72 hours to make sure that this patient is going to do well. And they are the reason why I'm here to present this data to you. And this is just like an advertisement. So I have a YouTube channel and I have almost 50 different videos. So if you are interested, you can scan the QR code and you can watch my YouTube channels. I will stop here and I will try my best to answer any questions.
Thank you, Dr. Ahmed, for such an exciting and nice case. There are few questions for you. Before going to the question, just an introduction of Dr. Ahmed. In fact, he was here last week also for the EHS conference where he presented great talks about the HLA labs. HLA, and which is very puzzling to most of the colleagues. So the question is, 4 sessions of plasma exchange prior to DD transplant. It's really challenging decision. It's done daily. The question is, the plasmapheresis was planned for daily, or it is an alternative days or weekly, or what is it exactly?
I believe it was twice a day for 2 days because this patient was a deceased donor, but the patient was still in a life support. So the patient, the donor was still in a life support in Edmonton, and they were not weaned from their life support, so they were able to keep the kidney function for 2 days, so which was sufficient for this plasmapheresis. But I personally, and at the end, we think that there was no need for it. The patient has some sort, because flow cross match is a cell-based assay, and the idea of getting false positive can happen anytime, and I'm pretty sure you have seen it. But this case was puzzling because it is an HSP case. The patient has an allele-specific antibody. So this is why they went for extra cautious with this patient. But if this was a regular patient, I don't think this patient need this plasmapheresis. And again, I'm not a nephrologist.
Yeah. You showed such a nice collaboration between the nephrologist and the HLA director and the surgeon in taking the decision, which makes a great effort. The next question is for being virtual cross-match positive. What's cut off for class 1 and 2 DSAs?
So we use the cutoff for virtual we are very, like, our center are very conservative center. So above 1,000 MFI are considered positive. I know some people will fight with me and they say this is too low for a virtual cross match, but our center is very conservative because our province is very small. We don't do, I think we do like around 75 to 100 transplant a year. And we don't want any transplant to get to fail. That's why we use a lower cutoff in the virtual cross match.
Another question, very interesting talk, Prof. We can understand that highly sensitized patient, we should go for allele specific HLA typing directly.
Yes, definitely. And this has now become a policy. Every of our highly sensitized patients, we type them by high resolution typing because it's very important in the middle of the night to decide when you have an allele specific antibody. So definitely yes. If you have the technique in the lab, yes.
Any more questions?
And also, we are in the process now of doing epitope matching, and we are actually one of the first few provinces that started the epitope matching, and you need high resolution typing for the epitope matching.
That's great. Thank you very much, Dr. Ahmed. Thanks a
Dr.
lot for
Amna, actually, I
leading me.
have one question.
Yes, please go ahead, Dr. Mohammed.
Dr. Ahmed, thank you for the great talk. My question is, do you guys do CDC cross-match in
No.
your HLA lab? So why not do it in
No.
this case when you are not sure? Would it add any value? Thank you.
Well, CDC, I'm not sure if it's going to add any value because CDC is actually the people who invented CDC say it's an obsolete technique now. And most of the lab now have been switched to flow cross match, which is more sensitive. So if flow cross match is positive, then I would say that the CDC will also is going to be positive as well, because the flow cross match is way more sensitive than CDC. So I don't think it will add any value here.
Yeah, but the CDC is more functional, right? It will show you that the complement is fixated, the cell has lysed. So
That's right, because now there's something in the serum of this patient is actually interfering with the assay. So I think it also will interfere with this, because CDC has also other interference as well. And we don't do, like, there is no Canadian labs do CDC anymore.
Thank you.
Yeah.
Okay, if there is no further questions, then thank you, Dr. Ahmed. Thank you again for having you with us today.
Thank you so much. Thank you.
We'll